just magically have something, or I'm doing something wrong because that's possible. Oh, there we go. All right, same button, different outcome. So this is what I want to talk about. So I want to tell you a little bit about our Rural Health Equity Research Center. I just alluded to it. I'm going to talk broadly about rural health inequities. We're going to start at the high level, United States, then we're going to get into Region B, so Southeastern United States. And I do want to touch a little bit on the Appalachian Deaths of Despair, which is some work we've been doing both at NORC and ETSU jointly. All of our states, except for one represented here, have counties in the Appalachian region, so I thought it might be relevant. Then I'm going to shift gears a little bit and talk about the impacts of poverty. And I believe that poverty underlies most of the health inequities that we see, so I'm going to talk about that quite a bit. I talk about that more than social determinants, because I think that when you look at those social determinants, what you actually find underlying most of those individual determinants is still poverty. And then we're going to flip the script a little bit and talk about prosperity. And then I want to end on a positive note talking about strengths and assets. This is something that really is meaningful to me, and I think it's something we all need to be thinking about more as rural advocates and rural people, is we need to lift up our communities and not only talk about the challenges we face. Not that we want to ignore those challenges, but there's a lot of good in our communities as well, and we need to also lift that up. So this is what I mentioned to you. I wear several hats, we wear several hats, so we have some branding challenges probably with this, but when we do work in our state and in Appalachia, we really refer to our state-funded Rural Health Research Center, which is the ETSU Center for Rural Health Research. When we're working on that national level, we're really pleased to have that federal funding, and that is housed within our Rural Health Equity Research Center. This is a collaboration of actually 3 independent research centers, 2 at ETSU, 1 at NORC. So it's my center, the Center for Rural Health Research, ETSU's Addiction Science Center, and then NORC's Water Center for Rural Health Analysis. Together we form the Rural Health Equity Research Center. So this is where I want to start. And this is where I always start this discussion. So what you see here is mortality rates, age-adjusted mortality rates for the United States as a whole, so this is everybody, and the rural United States. So this isn't rural versus urban, this is rural versus everybody. So rural is actually included in this line, and if you did an urban line, it would be even lower. The reason I show it this way is that we have a narrative that we like to describe in the United States, which is we're the healthiest nation in the world, we have the best healthcare in the world. I know all of us in this room would challenge that, but what we often point to as our evidence is we have had declines in mortality rates, generation after generation. People are living longer, people are getting healthier. But even if you buy that narrative, which again, I know most of us don't, but even if you buy it, rural America has never been a part of that story. And that's really what I want to point out. In rural America, our mortality rates have slowly increased, even as a whole, mortality rates have gone down. The inequity, the difference between the two, the delta between the two has gotten greater. That's, I think, where we begin this story. Whoop. I'm using this and it's not connected. When we dig a little deeper, so this is data from the Centers for Disease Control and Prevention. What we find is that rural people face inequities on all of the leading causes of death. This is the 5 leading causes. If you roll this out to the 10 leading causes, rural people have health inequities on 9 of the 10. And what you see here, these are our rural definitions. So I might not need to explain this to a group of rural people, but I think it's notable because what we call these definitions is just stupid. Like, we got to come up with better names to describe rural. Micropolitan and non-core are 2 rural definitions. Yeah. Micropolitan is probably the most confusing because it sounds like metropolitan, and of course that's urban. Essentially, non-core are your remote rural communities. Micropolitan are your small town rural communities. Those 2 are our rural, and then all of these others are our urban. But what's notable is for each of these 5 leading causes of death, the more rural you get, the greater the disparity. So we have inequities for each of the 5 leading causes, and those inequities are greater as you get more rural. And again, you could push this out to the 10 leading causes of death, and you would see this for 9 of the 10. So on your table, each of you has one of these sheets for your state. And I just want to walk through this a little bit and tell you what you're looking at, because it may not be intuitive, but once you get it, you get it. And I might be underestimating. Maybe you get it. It wasn't intuitive for me. So it might just be me. So this is the 10 leading causes of death. This is what I described. So the example I have here is for Kentucky, and this is for females in Kentucky aged 25 to 64. So when you look at your sheets, you'll note that one side is females, the other side is males. So those rural definitions I shared with you are the color codes. So yellow is micropolitan, red is non-core. So those are our 2 rural definitions. The other is rural. So 100 here is the national average for each of those leading causes of death. So what that means is anything above the line is worse than the national average, anything below the line is better than the national average, and then the scaling. The scaling is where it gets important. So again, I'm looking at Kentucky here, and you see that this red dot for lower respiratory disease is right around 300. That means if you are a female in the state of Kentucky and you live in the most rural areas, you are 3 times more likely to die from lower respiratory disease. You're 2.5 times more likely to die from diabetes. You're more than twice as likely to die from unintentional injury. That's how you read this. Now, what's notable here is when you go through these, there are kind of, I would say, 2 types of states in our region. There are states like Kentucky and Tennessee and Mississippi and Alabama, where pretty much everybody is above the line, but you still see that blue does generally better than red, so we still see those rural-urban inequities. But then we also have states like North Carolina and Georgia, where the red is above the line and the blue is below the line. So these are fascinating states to me. In our region, there's some others around the country as well. But we still see these very dramatic health inequities for our rural populations, even as our urban populations in those states do better than the rest of the country. So I don't know necessarily what the takeaway is on that. We all have work to do. The takeaway for me, I guess, is that rural needs to do better everywhere. But I think in states like North Carolina, Georgia, Virginia is another one. I think the level of income disparity is probably what's driving a lot of that. I'll get back to that when I talk about some of the income issues. Does anybody, so again, each of you has those. Does anybody have any questions on those before I move on? Yes?
Nellie wants to know from Montana if these dashboards are available for all states.
These dashboards are available for all states, and if anybody wants to shoot me an email, I can send the dashboard for your state. Yeah, that's a great question. This is a project we did at NORC, and it needs to be updated. So the big thing to note here is we aggregate 3 years worth of data to be able to report the data. And the latest data we have in this is from 2017. The 2019 data is now the latest data available. Actually, 2020 data is the latest data available. They lag about 2 years from CDC. So this needs to be updated. We did this previously in 2015. I will tell you the trends are pretty much the same, but you still want the most recent data you have. And what I suspect as we bring in the COVID data is some of what we're seeing here is going to look worse than it did before. That's a whole nother discussion. I'm happy to start that discussion with you guys if you want. But what we see just in terms of COVID data is there's direct mortality related to COVID deaths, but there's also secondary deaths related to COVID. So we're actually seeing really dramatic increases in some of these leading causes of death due to COVID as well. Things like heart disease, which has gone up dramatically because people with chest pain are afraid to go to emergency rooms, things like that. So there have been other consequences as well. All right. So I'm going to shift gears a little bit and walk you through this work that we did. We did this for the Appalachian Regional Commission, looking at Appalachian deaths of despair. We just got new funding from ARC to update this. So we've done this twice now. So the latest data we have in this is 2017 data, actually 2018 data. And the data we had before was 2015 data. Now we're going to be able to bring in 2020 data and get the first year of COVID-19, which again, with those indirect deaths, we also saw huge spikes in overdose mortality in particular. So for those of you not familiar with this concept of deaths of despair, I'm going to tell you what they are. I'm also going to give you a disclaimer and try to distance myself from it as much as I can because it's not without controversy. So what they are 3 causes of death: overdose mortality, suicide, and alcoholic-related liver disease. This was a term coined by 2 economists at Princeton University who, when they were looking at data, saw these huge spikes in mortality for white working class populations. And they determined that these were in communities that were struggling economically, and so they thought this must be related to despair, joblessness, hopelessness, depression, all of these sorts of things. So they coined this. So on the one hand, I kind of like that. It paints a picture. Calling it deaths of despair paints a picture, and it's great in terms of describing this, and it's great for advocacy. What it also does is it leaves out other populations who face other issues, and that's where the controversy comes in. So if you are living in a community where gun violence might be your problem, that may skew more towards a lower income urban and African-American population. You may consider that despair as well. If you're looking at white working class people, you get some causes of death. If you're looking at other causes of death, you may be drawn to other people. So I put that out there as the disclaimer. For us in Central Appalachia, this works pretty well. Southern Appalachia, not so much. Central Appalachia works pretty well. So for those of you not familiar with the Appalachian region, I'm sure most people in this room are, this is it. It is 422 counties spanning from southern tier of New York down into Mississippi. This is what we found, and I'm going to walk you through some of this because it's pretty striking. So when we looked at this in 2015, there was a 37% greater likelihood from dying from one of these causes of death if you lived in Appalachia as compared to everywhere else in the nation. 2018, it was roughly the same, 36%. But when we look at the composition, it changed. So 2015, you were 65% more likely to die from overdose if you lived in Appalachia. That went down to 48% in 2018. Should we celebrate? Is that a yay? Lower disparities, that's good, right? Well, look at the rates. In Appalachia, the rates went from 35.4 to 41.6. So even as the disparities went down, actually things were not improving. The reason the disparities went down is everybody else got worse. Everybody else got caught up to us. So there's a lesson in data analysis here, which is that the disparity is not the end of the story. You never want to lower disparities by having other people get worse, right? I mean, it's obvious. So there's still a lot of work to be done in our region. Even as I say that though, within our region, suicide rates and alcoholic-related liver disease in that 3-year time period increased 50% relative to the rest of the nation. Rates went up and the disparity went up. So again, even a worse story, a more dramatic story to share there. What's notable about this, I think, is who is being affected. So if you look at the age groups, 25 to 44, men 50% higher, women about 65% higher. These are people in their prime working years. This is an economic development issue for Appalachia, and we need to also describe it that way. These are also people in childbearing and child rearing years. It impacts on our children, adverse childhood experiences, childhood trauma. Also, other dramatic issues that cascade off of our opioid crisis. Things are not looking good when it comes to these deaths of despair in our region. But again, the story is not uniform, even within our 13-state region. Highest in Central Appalachia, West Virginia, the 3 Maryland counties, Ohio, Kentucky, Tennessee. Not quite so bad when you get down to Southern Appalachia. In terms of these causes of death, again, remember what I told you. These causes of death skewed towards white working class populations. And as you get down into southern Appalachia, the populations get much more diverse. That's why you see that. Doesn't mean that there aren't other causes of death that we need to be looking at in southern Appalachia. If you look at aggregate, you will find that all-cause mortality rates are much, much higher in our southern Appalachian counties as well. It's just other things that are causing. So we don't want to lose sight of that. All right, so let me pause there. That's all the data I'm going to share with you on health inequities. Any questions before I move on? I usually get a question about, well, why would overdose be lower in those southern states? Anybody have any hypothesis on that? I have one. So I think that, I'm going to just tell you. I think that what I will say is overdose in particular is really unique among our leading causes of death because it doesn't follow poverty the way that other leading causes of death do. So poverty is almost a perfect predictor for diabetes mortality, cancer mortality, cardiovascular disease mortality. Overdose mortality looks different. And I think that was the outsized influence of the pharmaceutical industry and where they marketed these drugs. And in fact, interestingly, this is my hypothesis, there is long-standing evidence that pharmaceuticals are not marketed to African-American communities. It's systemic racism in terms of who has access to life-saving medications. These just didn't happen to be life-saving and happen to be harmful. And lo and behold, there was a community that was protected, really not out of the goodness of anyone's heart. It just kind of worked out that way. And it's kind of fortunate it worked out that way. But yeah, I think that's probably what's up. So I will put that out there for controversy. Impacts of poverty. So social determinants of health. We've started talking about those. What I want you to see is social drivers of health. So have any of you heard people starting to call these social drivers of health? I see a couple of head nods. So this delights me. I love when people start to like come together on these things. So the idea that these things should be determinate is really negative. It tells you that in your communities, if you are poor, if there is a lack of educational attainment, there's a lack of access to services, a lack of transportation, well, throw your hands up. You're just screwed. Your health status is going to be bad, just write it off. There are communities that are doing well despite the challenges. There are things that we can do in our communities, leveraging the assets in our communities that we can do despite the challenges. So yes, these are important. They are major predictors of health in our community, but they are not determinant on what has to happen on the back end. So I like this terminology, social drivers of health. When you look at these, I said this up front, all of these are important. When we address social drivers, we need to address all of these. But if we want to figure out what is the single thing we can do that underlies all of this, I think it's poverty. And if we could invest our dollars one place, I would invest in economic development in our rural communities because that, I believe, will lift all those. So I think that's really important. So this to me is the story behind this. This is one of my favorite slides because I think it just tells so much of this story. So this is the employment index. This is job growth to and through the economic recession and then since the economic recession. So a lot of people probably would be surprised that rural and urban job growth was almost exactly the same up until and through the economic recession. Rural was doing just as well. Who benefited from all of the stimulus and all of the recovery? Well, that's where things differ. Urban America boomed. It was far better than before the economic recession. Rural America stagnated and never fully recovered. And the delta continues to grow. So, I'm often asked, I'm sure many of you are often asked, why are rural people so angry? This is why rural people have every reason to be angry. Maybe there are other reasons as well. But if your communities are left behind economically, you don't have a good future for yourself, your children, you have every right to be angry and disaffected and want something different. And that I think is really important. So what I want to do is I want to walk you through some slides that we've developed that I think shows this in pretty potent ways. So this compares, and I've got a few of these, this compares the 2% of the wealthiest counties in the United States to the 2% of the poorest counties in the United States. So disclaimer here, this is wealthy versus poor. This is not urban versus rural. But guess what? Almost to a T, all of those wealthiest counties are urban, and almost to a T, all of those poorest counties are rural. The correlation is really, really strong. And when we look at premature death, years of potential life loss, what we see is that there are 3 times more years of potential life loss in our poorest communities. In our poorest communities, people are twice as likely to smoke. They're 50% more likely to be obese. And then the one that always, got one more before that, they're half as likely to have college education. And then this is the gut punch. Children in our poorest communities are 6 times more likely to live in poverty. That's the difference between rich and poor in the country. So what does this mean here in Region B? So we've done this exercise in most every state in the country. It's interesting when you do it regionally as well. We've done it for Appalachia, and now we're doing it for the no-SOAR regions. So these are your 10 richest and 10 poorest counties in Region B. I'll let you look at that a little bit and see if you can make out some of those counties and what you think may be some of the factors with some of those, where some of those might be. Certainly we see Central Appalachia, we see the Delta, some of our southern counties. Too small? I'm sorry, yeah. It is a little small. Nashville. This is Research Triangle area. Oh, I'm sorry, this is Research Triangle area. This is up Napa suburbs. Yeah.
What's here?
Where are you looking? The Florida. So I'm going to show you the count, so don't worry. I probably should have stated I have the list here. Yes.
Just real quick question. Just a real quick question. I asked a question. Sorry. You were talking earlier, you said that what are the children in poor counties more likely to do or have? You just said that right before this one.
What was it? I'm sorry.
You said it was what are children in poor counties or countries most likely to do or have?
Yeah, so that was the percent of children who live in poverty, comparing again the 2% richest to the 2% poorest. In the 2% poorest, 6 times more children live in poverty. 6 times. Yeah, it's one of the most striking statistics. So I'm sorry, I should have told you that the list was coming, so you didn't try to get all of that. Lesson learned for the next one, right? So there you go. There you go. So again, Nashville suburbs, Atlanta suburbs, Research Triangle, and then the poorest counties are Central Appalachia, Delta, and Southern. Kind of the southern crest. Okay. So here's those same counties though, and this is what's really, really striking to me. So Williamson County, suburban Nashville, that's the wealthiest county in this entire region. Holmes County, Mississippi is the poorest county in this entire region. 5.5 times difference in terms of median household income. That's the level of disparity we're looking at. Okay, really, really striking. So I want to share some of that same data I showed you for the 2% on the edges for this region. So what we did is we compared those 10 richest to the 10 poorest. And this is what it looks like when we look at families living in poverty. So you can see the southeastern states all along here. So all of the southeastern states struggle with poverty as compared to the nation as a whole. National average 9.5%. You see all of the counties in all of the states in our region are worse than that. But even within, so again, comparing the 10 wealthiest to the 10 poorest, there are almost 6 times more families, or 6 times greater likelihood of families living in poverty in those poorest counties as compared to the richest counties. That's a huge difference. Now you may say, well, if they're the poorest counties, of course there's more poverty. 6 times is huge. Here's where it gets interesting to me. So if every county in our region had the same metrics, the same data as those 10 richest counties, our region would be comparable to the 2nd most affluent in the nation, statewide. 2nd most affluent state in the nation, so the 2nd fewest families living in poverty in the nation. And I jumped ahead. We're supposed to have one on the poorest as well. But you can see how those rank. So those poorest counties, we'd be down at 49. They're actually 51 states because they include District of Columbia. So we'd be 49 out of 51. But again, the difference between the rich and poor is really dramatic here. And then I showed you before years of potential life lost as well. Same thing. There are 2.6 times more years of potential life lost in those 10 poorest counties as compared to the 10 richest counties. And if every county in our region were comparable to those 10 richest counties, we would have the fewest years of potential life lost in the entire nation. That's what we need to aspire to. And again, you can see how that ranks here. And I'm not going to keep doing this, but this is what it would look like. So this is that same data comparing 10 richest to 10 poorest across those 10 leading causes of death. Huge disparities across every single one. And actually, what I do want to point out here is, I know these bars look hugely dramatic, almost twice as much, but when you go out to some of these on the edges, the disparity is even greater. The diabetes disparity is 4 times. So I'm going to shift gears a little bit again. I think actually, so I want to tell you about a tool we developed. So this is our Prosperity Index. And the reason I show this is that the Prosperity Index right now is buried within an opioid mapping tool that we developed for USDA. It's a little suboptimal because, as I mentioned to you, prosperity and opioids are not the best correlation. Right now, that's the only way you can get the data. I'm going to tell you what's coming with our center later, but I'm going to give you a preview right now because we're currently doing work with CDC to build out the Prosperity Index as its own tool. So that problem is being fixed right now, which I'm excited about. But in the interim, if you want the data I'm going to share with you, or if you want opioid data, this is where you can find it. So this is covered a little bit, but we have an Appalachian version of this tool, which is overdosemappingtool.org. And then the United States tool, it's called the Opioid Misuse Tool, is opioidmisuse.org. This is the USDA tool. This is the one we developed for the Appalachian Region Commission. Within this tool, you can click on any county in the United States, get the overdose mortality rates, and all of the correlated information. So socioeconomic and demographic information as well. Really useful tool if you're interested in looking in that space. Within it, we also have our Prosperity Index. So this is a tool that we developed with an expert panel, people really national leading experts in prosperity, poverty, measurement, and these are the 16 measures that we came up with as being predictive of prosperity. So again, you can see here we have them categorized into this 2x2 matrix. We thought about economic indicators and social indicators, and then we thought about risk and resilience. We didn't want to just highlight deficits. Again, that's one of our mantras. We wanted to also highlight assets, so we thought about that as well. And then if you look at these, some of these I think are really interesting indicators. They may not be what you expect. Voter participation rate is a great measure of social engagement. That's a strength in our community. But we also have a number of industry dependencies. So if there's one job, one major employer in your community and you lose that community, that's a major risk factor for that community. Digital distress, all-cause mortality. Number of hospital beds. Number of hospital beds actually we include as an economic indicator because that's jobs. The bigger the hospital, the greater the jobs. So these are those measures, and it was kind of interesting for us as we started to map this out because we weren't sure whether we were on the right track or not, right? It's hard to validate these things. So when we map this out, this is what we came up with. So the orange communities, the darker the orange, the lower the prosperity, okay? Those 16 measures I shared with you are all weighted equally, so none is driving this any more than the other. What do you guys see here? Does anything strike folks? I'm gonna strike it for you if you don't strike it yourselves. Strike it. All right. So this now is comparing our prosperity index to persistent poverty. So persistent poverty is a fascinating measure. Persistent poverty is a USDA measure. It's defined as counties that have had greater than 20% of their population living below the federal poverty line since the 1980 census, 1980, 1990, 2000, and on. 40 years of intergenerational poverty. Darkest. They overlap almost perfectly. That by itself helped us in terms of validating our tool. Other thing I do want you to note, I know it's a little hard to see, dark in the persistent poverty map is rural, light, there are a few here, is urban. About 90% of the persistent poverty counties in the United States are rural. This is a map of cardiovascular mortality.
Yeah.
This is a map of diabetes prevalence. I could show you any of these leading causes of death, and the greatest predictor will be lack of prosperity. But there's more. So this is work thanks to our colleagues at the South Carolina Rural Health Research Center. So what you see on the left now is where we have the largest proportions of African Americans living in the rural United States. Again, perfect correlation. Now you see where we have the greatest proportion of Hispanics living in the rural United States. And now you see where we have the greatest proportion of Native Americans living in the United States, rural United States. So the one exception to this is Central Appalachia. Central Appalachia has almost the exact same health outcomes as these other regions that I share. But essentially, what our prosperity index shows is Central Appalachia, the Southern Crescent, the Delta region, the U.S.-Mexico border region, and Indian reservations. That's where we have the deepest poverty. That's where we have the worst health outcomes. That's where we have this confluence of geography and race and ethnicity. The way I describe this often for people, and I think this is helpful, for me at least, is that there are independent contributors to health inequities that are tied to geography, where you live, and there are independent health inequities that are tied to race and ethnicity. And when those two come together, we find dual disparities and we find the worst health outcomes in the nation. The evidence for this is that rural Caucasians are less healthy than non-rural Caucasians. Rural African Americans are less healthy than non-rural African Americans, rural Hispanics, rural Native Americans. Across race and ethnicity, we have geographic health disparities. So there's something about where you live that contributes to other factors, other underlying factors that underpin our health inequities. There's something about geography that is additive. And that's what we need to be addressing. So I just want to show you how to get this data because I told you it's buried and I didn't lie to you. So this is our opioid mapping. So you go into the tool, you click on your county. This is Holmes County, Mississippi. You'll recall that as the poorest county in this region. When you click on View Details, you get the overdose mapping data. So I mentioned that you can get this for every county in the United States. You can see your overdose mortality rate compared to your state, compared to the nation, and then all of your data compared to your state and to the nation on those social and economic indicators. Within this, there's a button for See Prosperity Index, and lo and behold, you finally get there. So this is the Prosperity Index for Holmes County. What we did, so the whole vision behind this was put data into the hands of decision makers. So the idea here is that this can be printed or emailed, sent to community stakeholders, legislators, anyone you want to see it, they can see for each of those 16 measures, they can see how their county compares to their state compared to the nation. And then just for comparison, this is that wealthiest county in our region, Williamson County, Tennessee, and you can see those differences are pretty striking. And this is where I'm going to shift gears a little bit. So this is my pet peeve. This is what makes me guilty. This is what makes me lose sleep at night as a rural researcher. We get funded to do this awesome rural research to describe all of the problems in our rural communities, and we do great work globally. We can tell you just how bad everything is everywhere, and then the media write these stories. And this is all from the Washington Post. So and I could show you articles from the New York Times, from any urban newspaper in the country. This is how they view rural America. Yeah. And if business leaders are in those communities, if they're looking to invest, this is the narrative that we have to overcome. You wouldn't invest in these communities. You wouldn't. So the way I describe this sometimes is we will do an article or a study where we say 5% of the people in the nation, I'm going to make it up, 5% of the people in the nation die from overdose. In our region, 10% of the people die from overdose. The article that gets published is twice as many people are dying from overdose in this region. And it's true. What they don't talk about, what we don't talk about is the other 90%, the vast majority of whom are healthy, productive, and longing for economic opportunity in their communities. Our rural communities are the best investment opportunity because you got people who truly want opportunity and will work twice as hard as anyone else. I absolutely believe that. That's the narrative we also need to share. So I like to talk about rural strengths and assets. So credit for this goes to the Robert Wood Johnson Foundation. They funded us to go to rural communities all over the United States. We went to the Delta, we went to the border, we went to Appalachia, we went to the upper Midwest. We went all over the country to talk to people in rural communities about what was good in their communities. What are you proud of? What do people come together around? How do you solve problems? And this is just a high level of some of the things we heard. Our communities are close-knit. When we have a problem, people get around the table and we solve the problem. Strong religious affiliation, our faith community comes together when in need. There's a lot of pride in our communities. We are self-reliant and independent. That can cut both ways sometimes, but by and large, we can address problems in our communities when we have them. A lot of loyalty in our communities and a strong work ethic, which again, I want to hammer home. Social cohesion. People collaborate. Everybody knows each other, so it makes those ties really easy. And then the last one is maybe to me the most important, innovation and creativity. So this is my theory on this. So what we heard in every community we went to a T, is that nobody is throwing money at our community to solve our problems. When we need to solve our problems, we get together and figure it out. And we do it in unexpected and creative ways. But we get the job done because we need to take care of our people. That's innovation. Our rural communities have figured out how to get things done without a lot of money being thrown at them. If we had a systematic way to identify, describe, evaluate, and replicate that, we could solve the world's problems. I might be exaggerating a tiny bit, but I don't think much. I think most of our problems in the United States have been solved in our rural communities, but we don't know it because they're just solving their own problems. They're not looking for national recognition. They're not announcing it to the world. They're not putting out a press release. So we don't know about it. We need to figure out how we find out. So one of the things we do, and this is a great exercise, is we take communities through this process of asset mapping. So we talk to them about the different types of assets they have in their communities. It can take a little time to get the ball rolling on this discussion because I will tell you some of our communities, especially in Appalachia where we work, some of our communities have been beaten down. They have started to internalize the external narrative, and that's the first thing we need to overcome. Once you get that ball rolling and get them talking about the goodness in their communities, the way people come together, you can't stop them. And it's a pretty cool discussion when it happens. It's energizing. People start thinking about those solutions. So I encourage you to do this. If anybody's interested in learning more about this, happy to talk about it. And then, just so you know, these reports, this is all the work we did from Rural Wisconsin. This is all available on the Walsh Center website. We put out several policy briefs. Some of them are focused on funders, some of them are focused on knowledge and culture and history. Really thinking about how do we energize people and engage people who can help with some of the resources. So I'm going to take you back to this map. So this is that same map of persistent poverty. So this has all been a lead up to this story. And this is why I don't like to talk about social determinants anymore. So we did some work with our partners actually in Eastern Kentucky at the Center for Excellence in Rural Health, where we just happened upon, I'll kind of tell you how we got this because it's kind of amazing. We happened upon this cluster of counties in Eastern Kentucky that were doing better than expected in terms of overdose mortality. The way we found this is I actually got a call, I don't know if you know this, I got a call from a reporter at the Lexington newspaper who was looking at our overdose mapping tool. And he was going through all the counties that he reported on. And he calls me up and he goes, can you tell me why overdose mortality rates are declining in Eastern Kentucky? And I'm looking at the national view. And I'm like, hold on a minute. And I start looking through and I'm like, lo and behold, he was right. I didn't even realize it. When we went to those communities, they didn't realize it, which is amazing. When I went to CDC to pitch the idea of doing this study, they initially said, you're looking at the data wrong. They didn't realize it. And they flatly turned us down. I got a call from CDC 2 weeks later saying, you know what, we dug into the data and there's something happening. And then they funded us for this. So, cool. Really cool. This is what's really interesting. Counties we're talking about are all persistent poverty counties. So again, if you believe in social determinants of health, what I'm about to tell you is not possible because outcomes should be predetermined. So this is another map. So what you're looking at here, and this is what's really striking. So we took that data and we essentially mapped it to, and within our overdose mapping tool, we have multiple years of data, 5-year aggregate data. So we looked at 5 years compared to the most recent 5 years and compared whether overdose mortality rates were increasing and decreasing. Darker the orange, the more the overdose mortality rates are increasing. The darker the green, the more the overdose mortality rates were decreasing. And check out these counties in Eastern Kentucky. That's where overdose, at that point, which is a big caveat, was decreasing. And then check this out. When we looked at every single county in the United States, 3,124 counties, I believe, and we rank ordered every county in the United States, 8 of the 10 counties with the steepest decline in overdose mortality were all clustered in Eastern Kentucky, 14 of the top 20. That's not an accident. The amount of this decline is stunning. So during the time that we looked at this data, the national overdose mortality rate was around 25.5 per 100,000. They have rates, they have declines that are doubling that. Okay? I also want to point out, because we can't ignore challenges, despite these decreases, every single one of these counties still has a rate that's above the national average. That's why when we went to these communities, they didn't believe us at first. And what I tell people is, if you're drowning, it doesn't matter whether you're an inch below water or 10 feet below water, right? But this is reason for celebration, and it's nice to be able to lift up communities that do well. So we did this project where we met with stakeholders throughout Eastern Kentucky. We met with, I think, about 40 stakeholders, and asked the question, what's happening in these communities? These are the themes that we came up with. So there was a dramatic increase in access to treatment services. That benefited from Kentucky's Medicaid expansion, but it happened before Kentucky's Medicaid expansion too. So Medicaid expansion added gasoline to what was already happening. Prior to Medicaid expansion, there were efforts to have voucher programs to get people into treatment within the region. Suddenly there was a way to pay for it, and the number of treatment spots exploded. Recovery community initiatives. So I don't know if any of you are hearing the new way people talk about recovery community, but I think it's awesome, and I encourage you to look into it. I'm happy to talk if anybody's interested. But people are now talking about recovery ecosystems. How do we create an environment that is supportive of people in recovery in our community so they can maintain that recovery? A lot of what we would now call recovery ecosystems was happening in Eastern Kentucky. The criminal justice system got on board. There are now judges in Eastern Kentucky who are more likely to refer people to treatment than incarceration. Some of them are like trusty old judges who you would never expect as the ones who would be the ones referring people into treatment, but they do because they believe it. They've seen the outcomes. And one of them told me that he didn't do it because he was a bleeding heart. He did it because his jails were full. He needed to try something new, but he became a believer once he saw the outcomes. That's how we get people on board. Harm reduction. So this is one that blows me away. So I started my public health career in Pennsylvania in the HIV Bureau of the Health Department, and we could not get needle exchange programs in Philadelphia. Rural Kentucky has more needle exchange programs than any state in the nation, just in the rural areas. People came together and said, we need to try something different. Came together. A lot of efforts to reduce stigma, a lot of partnerships, a lot of primary prevention and education. Again, we don't want to wear rose-colored glasses. None of this was easy. There are still people who are resistant. There are still challenges. But my take on this is that things got bad enough in Eastern Kentucky where they gained this critical mass of people who had had experience, personal experience, family experience, that suddenly some of those barriers started to melt away because now it's my problem. It's not somebody else's problem. We don't want everywhere else in the country to have to get to that level of challenge before we see the light. We need to learn from these successes. But at the same time, there's also been shifts in drug use patterns.
Yes.
So even as opioids have gotten better, methamphetamine got worse. And we need to be keeping methamphetamine top of mind because methamphetamine is a bug. It just is. We do not have medication-assisted treatment. We do not have good ways to treat people who use methamphetamine. We need to figure that out. And then all of the work, all of the data we looked at was pre-COVID-19. And just to jump ahead, this is what has happened with overdose mortality since COVID-19. So this is the beginning of the pandemic. We were all celebrating the first decline in overdose mortality that we had seen in decades, and then it all went to crap. That's a technical term. I mean, it's just, things are bad now. Things have gotten worse, at least in Kentucky. They've gotten worse nationally. What I say, though, and I believe this, is that the systems and structures that were built in Kentucky did not go away during COVID-19. They are poised to recover better than any of the rest of us when it comes to overdose mortality. And that's what we need to be looking at. This is the reports that we developed for CDC. I'm really proud of them. I encourage you to look at them also on the Walsh Center website. If anybody has trouble finding them, just reach out to me. And then this is what's coming for our center. So I mentioned this CDC product. So we are building a standalone version of that Prosperity Index tool. It will have COVID-19 overlays and other leading cause of death overlays. So you won't have to dig to find that tool. That map I showed you, which actually does not exist in the current tool, will be the base tool. So you can see that map of prosperity. Really excited. We are developing a similar tool for HRSA called the Rural Recovery Ecosystem Index. So we're essentially using the same process, but we're thinking about what are the indicators that measure the relative strength of rural recovery ecosystems. So second chance employment, recovery housing, treatment availability, all of these sorts of things. How do we measure that for every county in the country? Map it, provide that data back to communities and say, here is where you can invest to increase the strength of your recovery ecosystems. So that's coming. We're doing that with the Fletcher Group. And then our Rural Health Equity Research Center, each year for HRSA, we do 4 new projects. We're currently doing projects focused on mental health stigma. That's a fascinating project because we did a national survey with the hypothesis that there would be more stigma towards individuals with mental illness in rural communities. What we found is people in rural communities hold no more stigma than anyone else. And the people who do hold stigma in our rural communities are the same people who hold stigma everywhere else, older people and men. That's where we need to focus, older people and men. And if you find older men, you don't want any of those people, right? We're doing projects on hospital bypass. We're looking at block grant funding, so whether block grants that come from the feds to the states, whether there's actually filter out to rural communities or not. A lot of exciting work going on. And this is where you can find me. And I'm happy to answer any questions anyone might have. Yes, please.
So it was about midway through the presentation, you looked at hospital beds in communities. Have you looked at labor and delivery? Because, as more hospitals stop providing labor and delivery, we go to when big systems come in and buy
Sure.
other systems and they close the labor and delivery. And this hospital, when you talk about, turning our resource on the communities of businesses that are located there, if the people that work with business can't have doctors are going to move away because they're not going to drive an hour.
That's right.
Is that a factor in some of your analysis?
So that data is available, and it's data that all of the rural research centers look at all the time. I mean, and you just keyed in on all of the reasons why it's important data. For the Prosperity Index, we were limiting it to 16 measures. So we did not go to that level of granularity on the hospital data within that tool. But that's certainly data we have and we use for other projects, including economic development projects.
So one of the questions, so for the hospital bed data, did you look at what hospitals licensed for, or how many beds they actually are required to use?
We looked at, I don't want to get it wrong, so I'd have to go back and look.
Yeah, because a lot of ours, you might have to licensed
Sure.
hospital that's licensed for physician,
No.
but in reality, actually.
Yeah. No, it's a good point. Yes.
Is that being pulled off the cost report data?
So
That's where we can get the difference between licensed versus.
Yeah. I do not think it's pulled from cost report data. So we have identified national data sets for each of these measures. So for that Prosperity Index, same for the new index that we're developing for recovery ecosystems, the 2 criteria for every measure, one is that the data are organized at the county level because we're creating a county level tool, and 2, that data is available uniformly in a national data set for every county in the country. So I don't think we're looking at cost data. I think we're looking more at licensure data. But those are the criteria, again, and that's a limitation of the tool, because we know that if we were to do these exercises at the state level, some of you have better data that's just not reported nationally. You collect it from your own states, but we don't have the resources to do one-off versions in every state, so, yeah.
It's interesting to do like just a little pilot where you know, pick just a few to see
Yep.
how that number changes when you move from licensed sets to active.
Yeah, it would be. Yeah, I'd love to talk about that. And you know, when we were doing our overdose mapping tool, we had talked to some states about doing state versions of the tool where we could pull in some of that other data. So I think this could be another example of that. Yeah. Yes.
Most of our data was up through 2018. I definitely understand that it takes a while for more recent data to become available. But since the pandemic and everything, we forecast any changes in anything.
Yeah.
But they're kind of remain on the same trend, like getting better.
So everything is getting worse. We do have some of the 2020 data that we're able to start looking at. So that's just data for the first year of the pandemic. We know that things didn't get better in the second year of the pandemic. So I do have some of that data that I include in other slides, and I'll tell you what's fascinating about it is, so CDC has data on excess mortality by week within the calendar year. It's fascinating if you haven't looked at it. So when you look at 2020, for almost any cause of death, week 12, suddenly there's excess mortality. Cardiovascular disease, huge excess mortality. Now it started to come down a few months later, but didn't come all the way back to normal, down to normal. So what that is, so excess mortality is, we know what the rates of mortality for cardiovascular disease should be each month. We know how many people we would expect to die each month. If that is hugely above that, something else is going on. And that something else was COVID-19. It was people who were afraid to go for preventive services, afraid to go to emergency rooms. You know, I mentioned having chest pain, and don't take me to the ER, that may be COVID. So we saw this huge spike in cardiovascular mortality in 2020, huge spike in diabetes mortality. Those are those secondary impacts related to preventive services. We also saw huge spikes related to overdose mortality and suicide. Those are more related to isolation, lack of people being able to have continuous treatment, things like that. So yeah, I expect a lot of this is going to get a little worse. Yes?
We're going to see if this works. Graham has a question online. I'm going to ask him on mute. Let's see if this works. Just do this.
Can y'all hear me?
We can.
Okay. Fantastic data. I think it really helps, again, to shine a light on the challenges that we're having in the Southeast. So often when the national dialogue and national solutions are identified, they're pointed at frontier areas and their solutions for Montana and South Dakota and places like that, when it's the Southeast and the Southeastern states that are really struggling the most. And the data has shown that for years. So thank you for doing this work. What the data tells me is that as a group of state offices of rural health in the Southeast, we need to be pushing the national dialogue to say, we just don't need money for provider-oriented solutions. We need resources to fight poverty and to get at those root causes, because in essence, we should always do things to support our rural safety net system and make sure hospitals and clinics and health centers exist. But if we're not addressing some of these core factors, it's really not getting it where we need to go.
Yeah, I couldn't agree more. And the only thing I will add to that, which concerns me a little bit, is I do think that each of us working in our own sector sometimes feels like we're competing with the other sector for resources. So I worry a little bit that people who work in the health sector feel like, well, if we support people in economic development, it's a zero-sum game and that's going to come out of our budget. It may be legitimate, but I think that's something we need to be mindful of as we think about how do we partner better, how do we engage. But I couldn't agree more. I think the solution in its simplest way is to lift up our rural economies. And I do think that a lot of these negative health indicators will improve when our rural economies improve.
Agreed. Thank you.
And I'm sticking around for the whole meeting. So if anybody has any other questions, don't hesitate. All right, thank you.
Thank you.